Perfect. Is that good? Okay. Good morning,
Yeah.
everybody. I'm Priya Gupta.
Nathan
This is
Radcliffe.
Nate Radcliffe, and we're talking about not a typical booth talk title here, but we're here to talk a little bit about education and peer-to-peer education in particular. So over these next 20 minutes or so, we hope to share some insights on things we've learned over the years, but also introduce some educational initiatives that kind of came out of the pandemic. Wouldn't you say, Nate?
Yeah, definitely.
So I'm going to just put our little slide here up. So the traditional ways in which we get educated, right? We come to meetings, we learn things, but we don't always take back what we learn and put it into practice and implement it. So Nate, tell me about kind of your process on what happens when you see a new technology, learn something new.
Yeah.
How do you actually get it to work in your practice?
So, I sort of came into my practice at a certain time, really, which was the beginning of the MIGS revolution. I was trained in glaucoma in 2007, 2008, and I can honestly say in the past 6 months, I have done zero of the procedures that I was taught in my fellowship. And I'm a busy surgeon. So what am I doing? All things that I had to teach myself or learn from my friends, or frankly, even from YouTube after my fellowship was over. And, I'm that kind of person. But as someone who champions a lot of these technologies, including endocyclophotocoagulation, which is brought to us by BVI, I realize not a lot of my colleagues learn and feel comfortable learning the same way. And not everyone is willing to take a new technique or new surgical procedure and just watch one YouTube video and then run into the operating room with it. That's one side of it. But the other side of it, too, is that even surgeons who have those technical skills don't always feel comfortable making the initiative to change, talking to patients about, hey, I've got this new laser I can offer you, I've got this new procedure. And so, in a sense, I spent a lot of my time embracing new MIGS technologies, but really kind of struggling to get other people to jump in the water, despite how safe and how good all these new techniques are. And so that's like the unmet need that I think I was expressing to you, and you have some similar issues in dry eye, right?
Yeah, I mean, I think anterior segment surgery has really crossed a lot of lines. And no longer are the days where the glaucoma doctors only do glaucoma procedures and the cornea doctors only do cornea procedures. And, part of it's that technology has advanced so much over time. And, when the pandemic hit, when our traditional ways of education sort of dialed back, I think it gave a lot of us time to reflect on, well, how is it that we actually like to learn? I actually like to go to YouTube and watch surgical videos, partly because it's always candid education and it's practical education. And so we started this educational initiative called the Interventional Mindset. It's a freely accessible website. It's www.interventionalmindset.com, but it's aimed at kind of shortening that gap of knowledge that's required to take something that you see at a meeting or a show and actually implement it into your practice. A lot of times we don't have all the answers for our staff. We don't know how, the logistics, reimbursement, billing, how do you talk to your patients? What do you do if your patients are unhappy?
Yeah.
And so all of the educational content on this site is aimed at, helping. If you're not a glaucoma surgeon and you want to do MIGS, here's how you do it.
Yeah.
So, Nate, walk us through a little bit about, here, I'm going to put up some of the website here. So, here, the glaucoma section. So, you're a glaucoma specialist, but I think you fully believe that glaucoma doctors should not be the ones driving early treatment of glaucoma in an interventional fashion.
So absolutely, and it's not just that, it's that as a glaucoma specialist, I want to be doing interventional dry eye treatments, and I want to be doing more refractive cataract surgery. I do a little bit, and so I'm kind of like looking at, okay, I want to share glaucoma with refractive cataract surgeons. I want them to teach me how to do refractive cataract surgery better. And so a lot of this is about cross-pollination, and then also about maybe the insight that maybe what you and I do isn't that different. Both of us have new therapies patients who haven't heard of them. Maybe there's some reimbursement challenges, maybe it's a self-pay model. We've got to talk to the patients, explain the value, believe in it ourselves, learn the techniques, and then change the way we practice. One thing that was fascinating for me was, Allergan recently came out with Durista. It's an injection, it's sustained delivery in the eye. I believed in it. And then I show up to my practice and proceed to not offer it to any patients because it's just something new, and I just went through the day and, it's like any other day. And I realized, wow, it's not enough to believe in the therapy. You have to practice the skill of adopting something new, and it's a different skill for us. And, this is very different from medical school where once you understood the disease, you prescribe a drug and you're off to the races.
Absolutely.
You've got to persuade a patient to add a laser to their cataract surgery and explain the value there for them and all these different things. So, we've covered a number of different topics on the glaucoma section of Interventional Mindset. One of the big ones, I think, is the injectable bimatoprost. It's a very new paradigm, and who are those patients? Well, they're patients who are, and I've gotten very good at this now because as a laser advocate, I know that patients who are controlled but red on their eye drops shouldn't be considered successes. I mean, they're unhappy, they have social issues related to hyperemia. A lot of patients have compliance problems, and those patients can all be helped by adding a glaucoma procedure at the time of cataract surgery, or a laser just in the office setting without cataract surgery. And so there's just been a lot of kind of focusing on how to identify patients who are good candidates. Ultimately, I do think, and those of us who do this all feel the same. It often comes down to a patient asking you what you think is best, and you've got to actually believe it. If you think it's equivalent, you may not end up being able to persuade them. And the good example that I use is laser iridotomy. All of us can convince a patient to have that laser. You switch to laser trabeculoplasty, which is arguably a better treatment than laser iridotomy, and people start to say, or you could have the drops. And of course, patients seize on the drop out and decide not to have the intervention. The reality is there's much stronger evidence for laser trabeculoplasty for glaucoma than there is for laser iridotomy for narrow angles. So we have to keep revisiting these topics and say, wait a minute, I'm dogmatic about the wrong laser. I should be more aggressive here. And I think identifying that it is a challenge for us is sort of the first step to fixing it in our practice. And we try to encourage those conversations. And that's why it's nice to talk to someone like you who hasn't been doing those procedures, or for me to tell you, hey, I get nervous about aligning a toric IOL. Give me some advice. There's a little vulnerability in there. Yeah.
Absolutely, and I think something you said is so important, which is that to really adopt a technology and be successful with it, you have to get that experience, but you have to be confident in that recommendation to patients in order for patients to really want to try interventional therapy. And I think that, no matter what field we're really talking about, those interventions are often, less invasive in other ways. They might achieve disease endpoints in better ways than traditional therapies, but your patient's not going to do it if you don't believe in it. And the goal of this education is really to help kind of take away some of the guesswork in, okay, well, why should I believe in it? Or how can I troubleshoot when things aren't perfect? Because, not all of us are in an academic institution. We don't have, 20 peers next to us saying, oh, have you tried this? Have you done this? The other, in addition to the website, there's actually podcasts that are also our Interventional Mindset podcast. And those are actually my favorite. I was never a podcast listener. The pandemic made me a podcast person because I have a trail in my neighborhood and I walk that trail like all the time. And it's you're like getting critical information. It's non-intrusive. And I don't know about you, Nate, but I feel like sometimes when you're listening to people talk about a topic, you understand it in a different level, in a different way, such that you can. It's more approachable, maybe more practical in some ways, but digestible is another word. But those to me are ways in which I sort of kind of listen to a handful of topics and get my foundation. Then I go to like more practical, detailed information, and then from there it's like the more advanced, like, oh, has anyone seen this or done this? And so kind of that
Yeah.
progression.
Yeah, I'll never forget. I was asking Priya. Priya converts a tremendous number of her patients to premium cataract surgery, and she converts a lot of her dry eye patients to therapies. And I just asked you, how do you do that? What's your approach? Like, why am I not doing that and you are? And it's one of the things that might be on one of our podcasts, but I don't know if you want to say a word or two about
honestly, it's about believing in an approach and a technology. And until you do enough of it, or actually some of the things that I've learned over the years in whatever technology it is, finding the sweet spot of that technology is actually the hardest part. Because if you can figure out what patient population is going to respond to procedure X or medicine Y, that's you need to find that, and that becomes an efficiency process of selecting out. We're people pleasers. We want to make sure our patients are happy, that they won't come back and be upset with us, and we hold ourselves to somewhat of an unreasonable standard sometimes. I also think that when we start talking about cash pay things or out of pocket, whether it's cataract surgery or ocular surface disease, we feel even more responsibility, which really isn't how the rest of the world operates or functions, but yet somehow in the doctor world. And a lot of it's just good communication and setting realistic expectations for your patients and knowing, hey, you have these 3 features, you're probably going to do better with this technology than that. And honestly, I think that's like the biggest, if everybody could kind of learn that, they would, I think, more readily adopt technology.
Yep. And so, it's interesting. One of the folks that's part of Interventional Mindset is Paul Singh, who will be back here in a few hours with me to talk about endocyclophotocoagulation. He's one of the most inspirational ophthalmologists I've ever met, and he's someone who really crosses a lot of borders with the way he treats cataract refractive for sure. He's an advocate for sustained delivery, laser therapy. I often think we're somewhat twins in that every time I get excited about a project, I find out Paul Singh's already an expert in it. But he's completely inspirational. And one of the things that I like about him is I really think he always puts his patients first. He's really always looking at their quality of life. And some of these things are, George Spaeth, one of the, pioneers of glaucoma therapy, taught me to really focus on patient quality of life. But sometimes it takes a little bit of a leap of faith to recognize that, I'm pursuing a new therapy and it's, it's avant-garde and it's something I wasn't trained to do, but I'm still focusing on fundamentals. I found the best place for this therapy and I'm going to help people, even though they need a little push. This is actually what's in their best interest. And that's kind of at the heart of what it means to be a doctor.
Yeah. Well, I think it's also unrealistic to think that you're going to learn everything that you need to know in your career in the 3 years of residency or plus your fellowship. And sometimes it's shifting that mindset of, I couldn't possibly take on that because what if I don't do a good job or what if I don't know? But really a lot of it is having someone to lean on, a friend, a colleague, colleagues that are trying to educate. I think to me that's more than anything over the last year where we weren't having meetings, you realize, hey, you can educate yourself and advance yourself and add to your tool belt without necessarily only having live meetings and only having, those other resources.
No, and so that also, there was something nice about the pandemic, not at all nice about the pandemic, but that the slowing down of the pandemic where things went virtual, and so there was somewhat of an equalizing factor that gave us the chance to kind of launch a video platform because no one was doing fancy video production. We're all shooting with Zoom, and that's sort of the platform we've adopted.
Yeah,
so
right. So here's screenshots. That's Gary in his clinic talking about what the interventional mindset means to him. Arsham Shabani, Dave Goldman, Paul Singh. There's just people all over the place. But, for example, one of my favorite topics actually is when you interviewed Dave Goldman and kind of talked to the cataract and refractive surgeon about entering into glaucoma, which you know, a lot of people are afraid to take on those additional procedures. They're afraid of, you know, the complications, and I put that in big quotes because it's not like you're doing trabs these days for glaucoma.
Yep.
But there's so many ways in which you can combine cataract surgery, you know, cataract ECP, cataract iStent, cataract, you know, like all, you know, to help ultimately take patients off of medications, you know, as a ocular surface disease specialist, something that, you know, we now are realizing, hey, all these three different areas are very much intimately related in so many ways. And I think that there's a lot of excellent doctors out there that are kind of practicing what we're, you know, talking about in terms of that intervention. But you're right, there was no high value production. It's people candidly talking about, you know, what they do, how they pick new technology, what new technologies they looked at, you know, just everything from, I don't even know how to get started to, you know, how do I deal with unhappy patients and things like that. So,
you know, it's such a good point. You know, David Goldman, cataract refractive LASIK surgeon, who loves glaucoma, and you know, he has a private practice, and you know, I think he's gravitating more and more towards glaucoma every day. He likes treating it, and he likes that he has tools that can almost equalize him to the glaucoma specialist, you know, down the road from him. And as I look across, part of the insight I think that we had is that whether you're a company that has glaucoma treatments, dry eye treatments, cataract refractive treatments, it's all sort of the same group of ophthalmologists that can benefit. The comprehensive ophthalmologist or the glaucoma specialist who's also a comprehensive ophthalmologist, or the cornea specialist like you or Dave Goldman. And that once you acquire a skill to adopt dry eye technologies, you've already got all the skill set to become a glaucoma early adopter, because it's really much more about stepping outside your comfort zone, finding out how to learn independently, and then implementing against some resistance somewhere. And whether that's glaucoma, dry eye, or anything else, you know, it's really all the same stuff. I mean, I dabble in retina, which draws a lot of you know, eyebrow raises, but you know, to me, it's part of the same process. And you know, in glaucoma, I haven't been able to go 6 months without a new glaucoma surgery coming for the past 5 or 10 years, and so something feels wrong to me if I'm in the operating room and I'm not doing something new. I mean, it's been that, and you know, I've been drawn along into that sea change, but I want to pull as many people with me, because you know, once you accept that the evolution just is sort of consistent throughout your career, it becomes really fun. You really enjoy that process, and then you want to see other people have the same benefits to their practice that you've been having.
Absolutely. Well, with that, we'll close, and we're happy to take any questions. We hope that everybody checks out the website and the podcast, but more than anything, bring back something new to your practice.
And Twitter. We're on Twitter.
Oh, yeah, and Twitter. iMindset. I forgot. Yeah. Thank you.
Thank you.